Welcome to another exciting episode of webinar podcast series by Dr. Online and Emergency Medicine Kenya Foundation. My name is Dr. Benjamin Washira, and I'm really excited about this evening's production. And so today we have a fantastic guest joining us, a very good friend of mine who has mentored me over the years, shown me how to do stuff. And I'm really excited to have him join us today, and I'll let him introduce himself. The exciting part is we work at the same institution in two different parts of the world. So really excited to have Professor Junaid Razzak joining us today. So today's discussion is mainly around trauma and trauma care in low and middle income settings. And I don't think there's an expert as good as you, Junaid. So maybe we could start with a bit of introduction of who are you?
Great. Thank you, Ben, and thank you, Dr. Ari, for this opportunity. It's wonderful to be here, to be part of this conversation. My name is Junaid Razzak. I am a professor of emergency medicine at Weill Cornell Medicine, New York. I also direct the Center of Excellence for Trauma and Emergencies at the Aga Khan University in Karachi, Pakistan. I have had an exciting emergency medicine career. I trained in emergency medicine in the US many years ago, worked there as a clinician in the emergency department, then moved to Karachi, which is the city I was born, and worked on establishing a fairly large, complex emergency department, started a new residency program in emergency medicine, and helped the country begin the journey towards emergency medicine. And while I was doing that, I had an opportunity to start an country's first advanced life support ambulance service. And Karachi, which is a city of 20 million people, we were able to set up I'm biased, but I think it was a pretty good service with physicians on the ambulances and nurses. And we were recognized by our peers. And we also ran a WHO collaborating center on emergencies and trauma. And a few years ago, moved back to US as a professor of emergency medicine at Johns Hopkins and a center director. And now I'm back in New York, and part-time in New York and partly in Karachi.
Good. All right. For those who are wondering why I'm wearing a t-shirt written Tipsy. So Tipsy is not that I'm drunk. So Tipsy is the Injury Prevention and Safety Initiative, an initiative by the Emergency Medicine Kenya Foundation that looks at trauma, bringing in healthcare providers to look at trauma injury research and prevention and looking at how best we can address our systems. So you said you've got a lot of experience in trauma development and trauma care in low and middle income settings. Maybe you could share a bit of what you've done, where you've done it, and how that looks similar to maybe our setting here in Kenya.
Yeah, many things, but a couple of things that come to my mind is working with policymakers in the province I was working. And I was the provincial in charge of trauma system development at the local governor's house. So that gave me a lot of access to policymakers, how they think, and what helps them make decisions, and how us as clinicians, us as academicians, help them make the decisions. So that was one role. And then, as I mentioned before, starting an EMS service in a private sector, and EMS is complex, so working across all sectors and making sure that people have buy-in to this. So that was second. And then, of course, emergency medicine development in terms of residency program and expanding it to multiple places was interesting. And I think all of that, and in my brief experience here in Kenya, I think is highly applicable. Of course, there are local nuances, but I was smiling yesterday when people were talking about the challenges, and it's a very similar story. If you just need to change the names of the players and the actors, it's such a similar story. It's amazing. And so, yeah, I mean, I think there's a lot of it applicable to wherever we go and wherever we practice.
Yeah, I think so. A lot of people, I'm guessing, but a lot of people working or watching this and probably working in settings where a lot of these things are not developed. And it's interesting that you say you started an EMS program, and it's what we really are trying to look at setting up in Kenya and setting up systems here in Kenya. And you've had the benefit of having experience from well-resourced countries, that's the US, I guess, and also working in low and middle-income country settings. So why can't we just copy paste? Why can't we just take, it works in the US, why can't we just take what works in the US and just plaster it all over our local setting? What makes our settings unique, and why do we have to think about this differently as low and middle income setting areas?
Yeah, no, it's a great question. The first, obviously, difference is resources. You have, say, for example, US spending $8,000 to $10,000 per capita per year on health. Pakistan spends about $60. So $8,000 and $60, big difference.
Yes.
Probably similar numbers in Kenya here. So we have to be smart about what we pick up from high-income countries, and we should be selecting what is most effective to apply in low-income settings. We get the best return on investment. The other difference is I feel like there is a lot more interest, even though people complain a lot about developing countries, low middle. I feel like if you can convince the right people, there is a very the openness to making changes is much more so in low middle income countries if you get the right partner on the ground. And in high income countries, because systems are well developed, changing something small takes forever. So, for example, in terms of EMS in Karachi, we went from no ambulance or ALS ambulance to 100 ambulances in 9 months.
Whoa, that's good.
In 9 months, we were able to recruit thousands of people in the service, make protocols, make it run, and achieve 8-minute response time.
Nice.
And that was possible. These are things that are possible in countries where there is real commitment and energy. You have a lot of young people who want to make a difference, which I sometimes miss in the US. You know, people are very calculated. They're comfortable in how they do want to do things. And in Pakistan, I felt like we were able to make rapid changes, put the right teams together, who would work, who will not look at their watch, it's 5 o'clock, I want to go home. They want to make a difference. I thought there was some of the differences between the two settings.
Right, good. And so, do we need to have that much money to make trauma care work in Kenya or in other low and middle income countries? Is this about the money, or what is it? What can we peg it? Can we say we're just too poor to provide trauma care in Kenya? We're just too poor to develop trauma systems in Kenya. Is it just the money? Or yes?
Yeah, and money is probably third in terms of barriers. I think it is the understanding and commitment. I tell you, in Karachi, when we used to run a fairly large EMS service I described before, for the population, at the population level, the cost was $1 per person per year or less.
Wow.
So
Per person per year?
Per year.
Okay.
So it's a cost of coverage, right? Per transport is more expensive, but not everybody in the population will need transport every day. You know, in a population, in our population especially, people would call ambulances when they really need it. And we were triaging on phone, and we were going to the real emergencies, and we were able to cover, as I mentioned, even 50 cents for the operational cost. Yes, there is some startup cost, but even then it is nothing. I tell you, the cost of running, for example, EMS service in Nairobi, I would assume, is less than the cost of running a medium-sized hospital. And so we have hundreds of hospitals in the country.
Yep.
And people are scared of starting EMS service. Once you start the EMS service, you will see the difference in how the system works. And if a politician was listening to me, I would say, if you want to get votes, it is the best investment you can make.
Yeah, we just have a new government check-in, so I think hopefully they're listening.
Yeah, because what you will see, this is a mobile, noisy advertisement of your effort. So that's a first part of trauma system. I think the hospital piece does not require a lot of money investment. It requires changes in how we do things. So I would say, putting trauma teams together, and we
Discuss that, yes.
working together, changing the culture, making some basic treatment protocols, that will start making a difference.
Oh. Okay, so I think there's the theory and there's the practice. So I think what us to do is just go into the meat of things, because we have providers from across the country, and yes, you need to go speak to your politician about getting ambulance, but we've seen that happen before, where people just buy ambulances or build in the system. So I think I want to understand now the practicality. What works? What have you seen from the science and from other areas, especially low and middle income countries? And we'll start at the community level. Okay, so I've been hit by a border in our setting out in the community. Community response. What models have you seen work in settings similar to ours? Do we go and train all the border riders in doing first aid? Do we train every school-going person in first aid? So what community models have been piloted in settings similar to ours that have worked?
Yes. This is such an important question, because in trauma care and in cardiac arrest and some of the major emergencies we deal with, minutes and seconds count. And even with the best EMS system, I would say, perhaps any city in New York, any city in Europe, any city in the US like New York, the response time is often double digit, 10 minutes, 12, 15 minutes. In many cases, it's too long of a time. And in our setting, we will not get the ambulance, at least in the short term, to do many of the interventions. So what can the community do? And I think there are two main things the community can do, and we can teach and train communities to do those things. Stop the bleeding.
Okay.
Nobody should die in the field because of bleeding, external bleeding. So stop the external bleeding if you see it, and get the patient to the right hospital if you don't have a proper transport system. So, a lot of people will bring the patient to the closest dispensary and clinic, in their sense, trying to help the patients out. But then that's not the place where the patient needs to go. So having open communication with the community and describing where to take the patient. Now, Border is a pretty interesting group because these are captured population, and they're also in the transport business. So if you can train them on stopping the bleeding and safe transportation to an appropriate hospital, I think you'll make a big difference.
What do you mean stop the bleeding? I mean, so should we go... So what are we going to teach the community members? What should we advocate in that every community member, when you say stop the bleeding, just apply a bandage or what is it?
Yeah.
Like, what are the practical tips? Because we want to go back to this community. We want to stop the bleeding. But how do we do that?
Right. So when I use the term stop the bleeding, I'm talking about stop the bleeding program.
Oh, okay.
Sorry, I should explain this. So stop the bleeding program is a program of American College of Surgeons, but this is a very basic set of interventions, starting with putting pressure on where do you see the external bleeding is.
How?
And take a piece of cloth, just go and put the pressure. People are scared of causing more harm. But if you see the bleeding, you will not harm by putting a piece of cloth, whatever you can get. The cleanest it is, the better it is. Put it for the 5 minutes pressure, and then, put a strong bandage around it. The second thing that, in some cases people are recommending, I'm not sure if we can recommend in our setting, is a use of tourniquet.
We don't have tourniquets.
Because we don't have tourniquets. So that's why I said tourniquets is probably a good idea in places where it's easily available.
What about makeshift tourniquets?
There is a debate around that. The debate is that they don't stop the bleeding because they don't have enough tensile strength to close the circulation. And at least based on the recommendations from some of the experts in this area, they say that we prefer not to use locally made tourniquets.
Okay. Has any study been done looking at use of local tourniquets, perhaps? Maybe something worth looking into.
Exactly. And I think, I was looking at, recently we were looking at this tourniquets, $25 or $10, $15. That is never going to be useful for us. And one of the things we wanted to do actually very soon in Pakistan is to get locally manufactured tourniquet. Try it out on some
Promote
mannequins.
local production.
Yeah, and
yes.
see at what pressure. You can have a mannequin with a blood pressure cuff on it, and see you can start bring the pressure up and see when the tourniquet stops functioning. So that's why I said tourniquet is useful if it's available. If it's not available, just using your two hands for pressure, just like we use two hands for CPR. Using two hands for pressure while the help is arriving, that is good enough. We are also teaching as part of Stop the Bleeding that if the wound is deep, put the packing in. Whatever close to you, put it in. Put the pressure.
So you can put any piece of cloth, as long as it's clean, I'm guessing. So my piece of shirt, for example, I can stuff it inside the wound to stop the bleeding.
Because nobody has said nobody should die of bleeding.
Bleeding, yeah.
And after head injury, the second cause of early death is bleeding.
Yeah.
And as you know, many bleeding are internal, thoracic, abdominal, and those we can really do little about without coming to the hospital. But external bleeding is also quite common.
Especially from interpersonal violence, for example. And we have seen a lot of it in some areas of the country. There's a lot of interpersonal violence, yes.
Especially penetrating injuries, knife injuries, bullet wounds. In those cases, if we can train our community members, our college students, border drivers, I think we can save a lot of lives.
Okay, good. So one thing we're going to do is potentially teach the community to stop the bleeding. Okay, so that's I think is important. You mentioned about teaching them where to take these patients. So where can they just take them to the dispensary? I know you've mentioned that but so what qualifies as an adequate place for someone in the community to take a patient who's been involved in trauma?
Yeah. Every system defines it differently. In the system I work in, or I'm used to, level 1 trauma centers are the destination hospitals.
We don't even know what those are.
and we'll come to that.
Yep.
Trauma care is the way to save lives is to stop the external bleeding and to stop the internal bleeding. And stopping the internal bleeding, for example, intra-abdominal bleeding, often requires surgery, except in one case where we have a medication that I'll come to that. And so one needs to get to a place where there is enough diagnostic available to diagnose that bleeding. And
so we're talking about ultrasound and potentially CT, but ultrasound, I think, and we'll get to the AD parts of it, but I think ultrasound is one of the things that you're looking for.
Absolutely. And ultrasound, and if this is of course, educated audience here with who knows emergency care, focused ultrasonography for trauma is a lifesaver. And early detection of that is very helpful. CT scan, where I practice in New York, every patient gets a CT scan. Most of them don't need it, but I think it's probably a lot of waste. In the setting here, ultrasound does the job.
So I think, if we were to just narrow it down to the bare minimum of what a facility should have, of course, it should have a theater services, but also should have an ultrasound and, of course, trained providers who are able to do focus assessment or sonography in trauma. For those who are listening online, feel free to put up your questions in the chat or put up your questions in the Q&A, and we'll try and address them so that I'm not asking all the questions. So feel free to put up questions, we'll be able to discuss. So we've looked at the community responders, and I think the message coming here is we need to educate our community responders on how to stop bleeding and also where to take a patient. So ideally, you should refer a patient to a facility which has a functioning theater and, of course, that has an ultrasound and training, staff trained on how to use that ultrasound. So I think that's a good message. So one of the things that we don't have is a well-coordinated ambulance access system. And multiple areas have actually bought ambulances and are operating in some level or other, but we do not have that emergency access number like 911 or 112. Is it worthwhile for us to invest in this? Is it, or can we just use different numbers to call different ambulances? I don't know.
Yeah, no, I think having single universal access number is critical starting point of a trauma system. And it doesn't cost a lot. It is the political will and somebody putting together a number. You can have behind that multiple ambulance services, but from public's perspective, having a single number is very important. I tell you a quick story. in Karachi, we had multiple numbers. Some were legacy numbers, old numbers, and politicians were struggling to stop some of the older numbers. So I used to go to schools, and I used to talk to school kids about the ambulance service and emergency care and what number to call. I went to one of the schools and I asked kids how many remember a number to call an ambulance. So, the class of 50 kids, about 10, 15 people rose their hand. And I asked them, what number would you call? And the most common number they said was 911.
Yeah, because of watching American movies.
I know, it's crazy. And I was like, I'm sitting in a relatively low-income school in Karachi.
Middle of Karachi.
And they know the number 911, but they do not know the number in Karachi.
Wow.
So
it's the marketing of it.
It's the marketing. Yes. It is how, and I don't know what kids are hearing, but say probably hearing from some of the video games or TV programs or something. So I think having one, and then we confuse people by multiple numbers. Have a single number, and you can use that number. I think it's very helpful, not just to send the transport, even if you don't have a transport, but to support the bystander on what decisions to make. Which hospital should I take this patient to? Okay, where are you? What are the injuries? I can tell you which. You can have 10 well-trained people on a call center, and they can manage a million patient population.
So it's not necessarily, yes, there's a need to have a dispatch system, I guess, with a number and a setting ambulance, but you actually just can set up the number to answer public calls and provide that public information that people actually need.
Right.
I think that's actually one different way of looking into it, and a very nice way of looking into it, because we always say, let's wait for us to buy ambulances, set up a dispatch center, get all the ducks in a row before we get a number in place. But I think maybe we should be advocating to get a number in place so that people know where to access information, emergency care information.
Absolutely.
I think that makes a lot of sense and is more practical. And I think that's also, you mentioned, so the role of telephone support. So what kind of information? So what's the benefit? So let's say we set up, so we do not really have enough ambulances to have them responding adequately. But what kind of information can this number provide? I know you mentioned it can provide, but what kind of information? So if we were to set up and put up people to answer the call, what kind of information should they be able to provide?
So I think there are two roles of that dispatch system. First role is to help assess the patient. And as you might know, the multiple algorithms that are quick questions on how is the patient doing. And so they can ask about is patient breathing or not, their pulse, start the CPR, patient bleeding, take a clean piece of cloth and push it and put pressure on it. Those kinds of very clear instructions can be given. So that's the one set of helping the bystander gain confidence on what they can and cannot do. That's number one. Number two, they will tell and assist the bystanders in deciding which is the right and appropriate facility for this kind of patient. If somebody has, minor scratches, they may not need to go to a large facility. They can go to dispensary, but there's a real trauma, somebody who is unconscious, has bleeding, significant bleeding, they should be taken to. That decision can also be done by dispatch.
The dispatch center.
And as you might have heard, I just finished my thought by saying, you might have heard about dispatch-assisted CPR.
Okay.
Now, they had that function can be brought to dispatch-assisted decision-making.
Because I think one of the things that people, the expectation, of course, is you'll be looking for an ambulance, but a lot of the things you're saying is the decision-making behind where should I take this patient? And actually, most people don't actually know where to take the patient. They will always rely and say, which is the nearest healthcare facility. So maybe having a dispatch function that provides that information, because most patients will still arrive in many emergency departments by private transport. So having a reference point to say, where you go to this hospital, don't go to this hospital because of that, I think is a very good point. And I think once we have that set up and have that number publicized, that would be some of the things. I see someone commenting on the chat about borders using elastic bands. So it's, as Junaid mentioned earlier, the science behind that is not clear. But as you say, just put pressure on it. Put pressure on it. If it's a penetrating injury, put something and put pressure and then just tie that around. So until we have very good evidence. I mean, that's one thing we need to look at in terms of the being able to stop the bleeding. Now, in terms of trauma centers, so we've not really gone into the definition of trauma centers. I know what we are working on at the moment is the issue of being able to define the emergency centers and then being able to make sure that these emergency centers can actually handle trauma. And we've done a lot of that work on that. For those, if you actually have the casualty app, it has listed for you. You actually have the geographical location of all the emergency centers in Kenya, both public and private. So you actually can access that information. What we're doing is to making sure that these facilities then are able to provide the service when you arrive. So that's still part of the work that we are working on towards. Okay, so I think in Kenya, 911 only works for, it's a police number. So 911 calls police. A good number of counties are looking to set up dispatch centers with single numbers. So it's good to explain even to policymakers that it's fine. We're not asking you to set up a number so then we have to demand ambulances from you. Right. But you can actually just set up a number to help Kenyans who are helping people in the community and being able to answer the appropriate questions. So I think the other question I really want to discuss, issues around EMS providers. How much training is required? Should we build them up all to become ALS providers because of maybe a longer pre-hospital times? So do we need more ALS providers or more BLS providers or people who have this first aid training? So I don't know what science has shown from the different setting. What should we do? Like, how much training is this required for this pre-hospital care?
Yes, I would say the answer is little nuanced. For urban areas, BLS type of training is enough.
Okay. So you said BLS is, I'm guessing, is above first aid.
Yes. So I'm talking about at least 40 hours of training. So
40 hours of training. Okay.
So 40 hours of didactic training and some ambulance-based training, some mentorship on the ambulance. So a person who hopefully has some background in healthcare can be taken through what we call first responders course, and they will learn how to provide basic care. In many, I'm not for advanced airway management in EMS, especially for trauma. It is doing minimum that's going to save life. It is stopping the bleeding and taking the patient quickly to the right hospital. So that for trauma care.
Okay.
For cardiac arrest, they need to be able to do CPR and do AEDs. If a person is not surviving with those, the chances are they're not going to survive. And spending any more resources on them might not be able to. CPR and electricity, automatic external defibrillators are two known intervention. And for other emergencies, it is really causing no harm and transporting the patient is going to be important. For rural areas,
which is pretty much whole of Kenya. But
with the transport time is going to be hours.
Yes.
I think you'll have to think about what are the critical illnesses you're going to be transporting.
Okay.
And in terms of disease entities, I will think about shock. Shock caused by trauma, but also very importantly caused by hemorrhage, postpartum hemorrhage, diarrhea, sepsis. Somebody who has skill set to manage shock.
Okay, so fluids. So we should be giving fluid.
Right.
Yes, okay.
Fluid management and being able to monitor, putting an IV in. There are studies that looked at giving blood during prolonged transportation. There's some evidence that they may help. Again, in the prolonged transportation, not in half an hour transportation, 15 minutes, because by the time you get the blood going, you should be in the hospital by that time. So I think from the Kenyan perspective, and I'll use my Pakistan sort of understanding, I think if you can get somewhere where people are, help them out, transport them, and treat shock, you can save a lot of lives.
Okay, so if we're looking at the skills, then our pre-hospital providers should really be emphasizing on and be more skilled on. So you said in an urban setting, you need more BLS kind of skills, 40-hour training plus. In areas where you're having long transport time, then the focus should be on shock management. So because I know we all get excited about airway management and all fancy cool stuff that we can do, but I think, as you correctly say, from a trauma perspective, shock is the biggest problem that we probably will be dealing with. And also looking at issues of So drugs, tranexamic acid, for example, I don't know.
Yeah, so if I had to carry a couple of drugs in the ambulances, epinephrine.
Epinephrine. Oh yeah, so for cardiac case and CPR, good.
Right.
Epinephrine.
Also for anaphylaxis.
That's adrenaline. I know people are like, what's epinephrine? Adrenaline.
Adrenaline. And TXA.
Tranexamic acid, yeah.
Now, tranexamic is very interesting because it is one of the few emergency drugs that have really been tested in experimental environment. Over 20,000 patients in, I believe, 30 so countries, and it shows mortality benefit, and it is extremely cheap drug. So you have the medication initially tested for blunt trauma, then tested for head injuries where it's a mixed results, then tested for postpartum hemorrhage. I think that is an interesting drug, and for stopping the bleeding is important while we try and get it for drugs. And then, of course, IV fluids.
Lots of fluids.
You know, whatever your normal saline, like Ringer's lactate, whatever you can give. And that will require ability to put an IV in. And those are the skills that you want.
The skills that are required. Because I think one of the things that we always, because I know there's some studies that look at, there's that discussion about giving too much fluids in the field. Yeah. Does that work? Is that an issue in our setting?
Right. I think it is an issue.
It's an issue.
It is an issue. We need to teach people what is a normal blood pressure. You know, we teach people that 120/80 is a normal blood pressure. But what is truly an abnormal blood pressure that needs treatment is very different.
Okay.
And over time, we have learned that we tolerate hypotension relatively better, and sometimes over-aggressive treatment can cause a problem. So yes, when the patient is, of course, has, blood pressure, or we call mean arterial blood pressure of 40 or, even 50, 30s, we need to treat it. But a mean arterial pressure of 60, so somebody with a systolic pressure of 90 over 60, I would be careful not treat. I'll watch it very, very carefully. I'll be ready to give fluid, but not push fluid.
Push fluids a lot. Okay. Yeah. So keeping your systolics around 90 or maps above 65.
Yeah.
So I think that works. So looking at some of the questions online, can mobile service providers divert 911 calls to active EMS numbers? Probably not, because these are private. So there's that challenge. So, but what we're working on is actually to have a functioning national single access ambulance access number, but also the whole idea of it just being a call center where you can get emergency access information is one of the things that I think we will definitely be looking to explore, because we have providers who can answer these phone calls. Yes, we don't necessarily have the ambulances, but you can provide that information that probably will be life-saving. In terms of, there's a reluctance to help a stranger in the need of hospital care for fear of legal repercussions should they make some mistake or treatment first aid. How is this actually? Yes. Is there, I think this is around the whole Good Samaritan discussion. Can you go to jail?
So nobody has been sent to jail.
Yes.
But everybody's scared of going to jail. It's a right scare.
Yes.
When you look at why people don't respond, it's a very important question. It is not that people don't want to help, but we have created either real or perceived barriers to people responding. And one barrier is medical legal thing. Now, if you look at some of the countries, for example, India, I think Iran, countries, and I don't know about this region, but I'm sure there are regional countries that have created Good Samaritan laws.
Okay.
And Good Samaritan laws it makes sense. If you're trying to help somebody, you should not be penalized. Good Samaritan laws basically guarantees that if you are a bystander, you try to help somebody and try to save their lives, you will not be asked questions. You'll not be penalized for it. You bring the patient to the hospital and then you're done. By law, nobody can call you. Once you start doing those kinds of things, you start removing barriers to people trying to help. So I think we are trying to do that in Pakistan as part of in the largest province, as part of the EMS. They've tried to give this Good Samaritan law touch, but not completely. This is one thing we would like to do, and perhaps here in Kenya it might be worthwhile.
I think something we can explore, because in our laws, I know everyone has the right to emergency medical treatment. I don't think you can actually sue someone if you tried help and stuff. So I don't think, I think it's there, but not really documented. Yeah. But I think just before I move into the in-hospital setting, You said you set up the EMS system in Karachi. Give us some practical tips how you went around it. So, assumingly, I'm going next week to have a discussion with a policymaker in my county, and they want to know, because I'm going to say, okay, so fine, we need an emergency access number, and we need to buy X amount of ambulances. So we need so many that have basic or just fast response. So, what are the practical things that you may have experienced and trying to judge how you should set this up?
Right.
So maybe from your experience.
Yeah, of course. So the first thing you need is a call center and a number. Okay. And the call center with today's technology, there are softwares available that will help you with EMS dispatch system. So the number lands in my system. Somebody will pick up the phone, will start getting the information ready, and when they get to the address and have asked a few questions, will pass on this piece of paper to the person next to you.
Is that practical? So you're writing it down, address is this here next.
Right. So that the other person is now looking at the screen or where the ambulances are, will contact the nearest ambulance and say, I have this address, this is the chief complaint, I want you to go there now. And
so who are these providers? We just want to stop. Yeah, so the person answering the phone, how trained are they? What's their training?
They get training in being a dispatcher.
Okay. How long is that?
Yeah, and that training is about a month.
Okay.
And the training itself is relatively short, but the practice takes a long time.
Okay.
And they are being monitored for how quick they're getting the information. And when they respond, there is a clear algorithm. There is a protocol, emergency medical dispatch system. It's available for anybody to look at. That is a standard throughout the world, same standard. So you pick up, first you ask the question, first thing you ask is, tell me your phone number in case we get disconnected.
So yeah, I want your phone number first. Okay, good.
So you write the first phone number. Where are you calling from? What happened?
Okay, so 3 questions. What's your phone number? Where are you calling from? What happened?
So they say, my mother is, for example, not responding. So then there is, on that dispatch system, there is an algorithm for what questions to ask for unresponsive patient. So you go to that and you ask 2 or 3 questions. And that algorithm will tell you exactly what is the level of response you'll need, what triage level. So those systems already exist. You need a call center with the dispatchers, obviously a number. You need a wireless transfer, in my case, wireless system so my dispatcher can communicate with the ambulance. And for that, we needed the wireless frequency, which does not compete with police or others. And that, for us, it took us a little bit of time, but because we're emergency service,
we got radio communication itself. Radio communication.
We use radio communication primarily because we felt that in certain areas the phone was not very good at that time. Now things have changed. So then the wireless network you need. Now to have wireless network, your command and control need to have wireless tower, and then you need to have towers across. Now what we did was, we put our own in some areas. In some areas, we went to mobile companies. Everybody has their towers. And we said, can we use your towers?
Use your towers. Oh, so you don't have to, because I think if you look at most of our mobile providers, they have towers across the country.
Yeah.
So we could tag onto their towers to increase the frequency. Yep.
So what happens is when you call a wireless, it sort of hops from one tower to another and finds the nearest tower and communicate. So that's the second thing you need. Then you need people in the ambulance and the ambulance itself. And how many ambulances do you need?
So when you started, okay, well, let's just start ambulance, then you tell me where you got trained providers from. Yes.
So we estimated standard is 1 ambulance per 100,000 population.
So is that based on any science or is it just something that you figured?
No, this is a science.
Oh, yeah, so 1 ambulance for 100,000 population. Okay.
I'm telling the Western, you can say, well, 100,000 probably is too little. Maybe I'll start with 200,000.
Okay.
Now,
but your target is 100,000.
Yeah.
1 to 100,000.
Right. So for a city of 20 million, we're thinking about 400 ambulances.
Okay.
We said we'll be happy with 200. Let's start with that. Start with 100, see how it goes. So that is the standard you want to get to eventually. And the second thing that will determine is, can I get to the emergency in the response time I want the emergency to be there? So you may have a very sparse population over a very large period of area. So your transport times are higher.
Yes.
So in those populations, you may put in an ambulance for a small population because your transport time is. But in city, you have 100,000, 200,000.
So you're factoring in the population size.
Right.
So for those who are online, maybe you can do the math for us. In Nairobi, we are 3 million people. So if you need one ambulance per 100,000, how many ambulances do we need in Nairobi? But then, so what transport times are we targeting?
Right.
We want you to get to the appropriate facility in how long? What's our target?
So we say the target was that every cardiac arrest, we think that every minute causes 10% reduction in survival. We should be try to get there before 10 minutes.
10 minutes.
Okay.
So response time of 10 minutes. So every person should be able to, from when you have an emergency, an ambulance should get to you and transport you to the hospital within 10 minutes. Or
by the time you call 911.
Yes.
To the time ambulance gets there, 10 minutes.
Gets to you. Oh, okay. So it's time to you getting to
Right.
you. Okay.
Yeah.
So when you're looking at it, so there's the issue of 1 is to 100,000 population, but everyone should be able to access an ambulance within 10 minutes.
Right.
Okay, good.
Now, I'm going to average time, right?
Yes.
So, when you are getting the phone call, I'll go back again to dispatcher. And when they're triaging patients, the current triage system that I'm familiar with triages patient from echo type of calls, which is the most severe, echo, delta, Charlie, beta, and alpha. You might have heard this in the EMS realm.
Yes.
And so if there's an echo call, you want to go get there as soon as possible because the patient is dead or dying. You have alpha call, this patient is not sick. So you say, this patient can wait 30 minutes. That patient I want to get in 5 minutes.
Which one? The echo one, yes.
So the average is 10 minutes. But you will play
from 5 minutes to 20 minutes. So that's good. Look, I'm seeing people have already done the math. So we only need 30 ambulances in Nairobi because we have a population of 3 million. Right? I know there are way more than 30 ambulances in Nairobi. So I think some of us really don't really understand the math, and which is good you're bringing it up, is we don't need 100 ambulances in Nairobi. Even when you're going to have this discussion at county level, the policymaker, you should be like, this is our population. We are 1 million in this county. We just need 10 ambulances. But I think the other part of it to look at it is that response time, as you said. So you want for your emergencies to be there within 5 minutes, for your non-emergencies to be there within 20 minutes. So on average, a 10-minute response time is what you're looking at. So those looking to speak to policymakers, those working to design EMS systems, some of the factors to think about, which is good. What's the other one?
So the other thing, then the question is, where do I park my ambulance? So you have to be smart about it, right? You say, I want to park my ambulances to reduce the response time. I know that this intersection has a lot of road traffic crashes. This area has other emergencies because it's very densely populated. You start putting your ambulances smartly, and you learn from the numbers you're getting. You start today, you may not be very good, but a year from now, you have data to prove, I think I need 3 more ambulances in this area, and I can work with only 1 in this area. So you start mapping out, and your your GPS, GIS system is helping you there. Then you come to the people in the ambulance. You say, for us, we wanted to go with advanced life support ambulance. Now, ALS means ability to give medications.
And fancy equipment.
Yes. And so equipment was okay, but for me, the risk was who is licensed to give medication?
Yes.
Yeah. Now, physicians are always licensed. Nurses are licensed if ordered by the physician. So we created a system where we had initially got physicians in the ambulances while we trained nurses, and then we had nursing protocols, and the medical directors signed those protocols, giving standing orders to nurses. If you see this, give this medication. So we created this system, got it approved legally and all that. Even though we are doctors and nurses, we trained them for 6 months.
So you trained the nurses for 6 months.
Initially for 6 months. We got them, we sent them to various emergency departments. We took them through the standard course that I described. But then we wanted them to experience emergency care in the hospitals. We worked with a few hospitals. They agreed to train our nurses, getting them experience of how hospitals work. Then they would have 2 months in the hospital, and then 3 months ride along with a senior person on the ambulance.
Okay. So interesting. So So we've been trying. So do you have EMTs in Karachi?
We do have EMTs in Karachi.
How does that work?
And somebody, we discussed today earlier that there was no licensing.
Mm-hmm. We have the same problem that you're trying to fix, yes.
And doctors and nursing societies were not accepting it. And initially, we had to go to the technical board of the government, those that give licensing for plumbing or other things, and they were happy to do it. Once they got license, and the license was giving them authority to practice, very limited one, we started to then lobby with the government.
For the government lobby.
And say, look, we want them to be able to do these very basic stuff. And that started to change things. We have limited interventions with EMTs, and those where we need critical transport, we still have nurses and their transport patients.
Because I think even in our model, yes, we have a lot of EMTs who have been trained and we're really working with the government to have them licensed. But I think in bulk of areas, there's still a lot of nursing. So I think one of the messages I'm getting from this is not just, you just can't pick up the nurse from the ward and put her in the ambulance and tell her to transport the patient. Right. There's a need for us to look at training the existing nurses who work in these ambulances to transport. And as I say, it's a 6 months training. So I think that's a very important thing to look at. So it's not just assuming that the nurse you pick up from the ward can happily transport a patient. So as we look at having EMTs licensed, but I think also looking at empowering the existing nurses into the EMS programs, I think is quite useful. So I think this is really good. I think very nice discussions. Thank you very much. And I think one of the things we can look at is now moving more into the emergency department. I think we've had enough insights into the pre-hospital setting. Tell me, in Karachi, were you there when they started emergency medicine? Or were you the one who started emergency medicine?
Yeah, no, I wrote the curriculum. I wrote the proposal. I went and presented multiple times. I was ignored forever. Yep. And then when they couldn't ignore me, they accepted it.
So what was your emergency departments before you set it up? Like what existed before, I guess, well set up EDs?
Yeah, so unlike some other specialties, EDs are always there. Mm-hmm. They're always emergency physicians who are attempting to do as best as they could.
So they're always doctors. I wouldn't say emergency physicians. They're just doctors who work in the emergency department.
So in my country, they'll call casualty medical officers or senior medical officers. They were untrained, not trained in emergency medicine. Some of them were good, some of them were not very good. There was a highly variable level of care. There was limited triage. People will be brought in based on first come, first served basis instead of who needs the care first. So we changed the triage model. We started to train people, first the medical officers. We realized that the facility was small and there was the entrance to the walk-ins and the ambulances and everybody was same. So we started to redesign the facility. Uh-huh. And the hospital I used to work at was very interested in creating a model emergency department. So we were able to redesign and expand our emergency department. We started the residency program, which changed the game. Right? And you have residents in the emergency department. They own the emergency department. They feel bad about poor care. They want to improve things because it's their identity.
I think we feel bad about poor care, yes.
Right. It's their identity. If somebody says your ED is not functioning well, they feel bad about it. They won't blame anybody else. They will come back and say, Dr. Razzak, I want to do this. We need to improve things, which was great.
I think that's because I think all of us have been told how bad ED care is in our individual EDs, even when things are working. And I think most of us have experienced that perspective where everyone says the worst part of the hospital is the casualty department. And I think a lot of people on this call probably work in those worst departments. So I want to take a step back in your journey because we are where you were before things were set up. And so we have everyone working in the same place, poorly designed, everyone coming in through the same entrance. So you mentioned the first part, triage, about triage and triage protocols, because we started a program where we're trying to push in the new, I think it came out last year, the WHO, ICRC triage program and making sure triage is set up. What is the benefit? Why should every ED, so I'm guessing if I was to say triage defines an emergency department, would I be correct in saying you do not have an emergency department if you do not have triage?
Absolutely right. I completely agree with you.
So the first part, if your AD doesn't have triage happening, then you do not have an emergency department. And you can go to Emergency Medicine Kenya website and you'll find all the resources around triage. But what's the benefit of triage? What will triage solve in our process, in our setting?
Right. People come in and they have different needs. And our job is to identify those who have the highest risk of death or disability early on. And that's why we do triage. Triage means sort out. The word triage means to sort. And by sorting means I want to know in the first minute of arrival, this patient has a higher chances of bad outcomes and this patient can wait. And when I make that decision, I can use my limited resources to take care of that patient. And that's what the entrance of any emergency department needs to have some form of triage, be it WHO, be it some other system, and all of them do the same thing.
So do I need to have been emergency care trained? Do I need to have been an emergency physician, or as a clinical officer attended the emergency clinical critical care course? Or can anyone set up triage? Do you have to need any, let's say, master or certificate level training, or it's something that as a department you can look at existing protocols, work out how you can go to implement them? Yeah, do we need anything special?
No, the whole point of triage is to make it so simple that you don't have to have complex thinking. See, in emergency department, in any emergency, the first thing to go away or compromise is your ability to think. So we want people to have processes that does not require a lot of thinking. It requires action. So you say, well, if the patient comes in, how do they look? Are they talking to you? Do they have a pulse? Do they have blood pressure? Do they have what is the respiratory rate? You take some vitals, you use an algorithm and make a quick decision. And that is what we need to do, and make it uniformly same across the country if you can.
Yes, and that's what we're actually trying to do. So we're pushing the WHO one, and we've done a lot of training in many facilities. So, I think the message I want to say is you do not have to be an emergency physician. You don't need to be an emergency care or critical care trained nurse. Each of your ADs should actually have triage available. And if it's not there, then you do not have an AD, you have an outpatient center, and you should be really fighting to get an AD happening, triage happening in your emergency department. So one of the things you mentioned is, so there's a triage component of it. Design, because most of our facilities, the outpatient / casualty was designed as a more clinic kind of setting. What would be optimal design for an AD? What is functional? Yes.
Right. Access is the number one thing, right? And you have easy access for people who are walking in, and then you have somewhat separate access for your people who are being transported either by ambulance, hopefully sometime in the future or now. And they do not need to compete with each other. Your sick patient should be able to get in. Your wheelchairs, your patients who are being brought in, carried in, they should be able to get in right away. And in my mind, I always thought that having an ambulance entrance separate from walk-in, coming to an area of triage.
Okay, so separate entrances for your walking regular patients, for your immobile or mobile assisted, so coming through. And so do they all end up at the same triage, or do they end up at separate triage processes?
I would like it to be the same triage area with two faces, one on the critical side, one on the non-critical side, so that you can, at night when you're not busy, you can have limited staff and you don't have to staff the two areas. So I like that kind of model. So there's one triage and you can increase and decrease the number of people in there. Once you are there, then you need to have very close to that area your resuscitation areas.
So triage and then a resuscitation area. Right. What you say, what's a resuscitation area? So I think we figured out triage, you needed to be able to have a set of protocols, vital signs. So we need to create a resuscitation. What's a resuscitation area?
Resuscitation areas are rooms with all the life-saving equipment and supplies.
That's normally not much in our setting, but let's go.
Yeah. So if you have to design something in the emergency department after triage, I would say think about a standardized resuscitation room model. You say every district hospital will have one or two resuscitation rooms. That resuscitation room will have IV fluids, it will have tourniquets, for example, will have vital signs equipment. I should be able to do cardiac, if I'm going to do shock somebody, I will have a defibrillator. all the basic stuff, they need to be there.
Does it have to be a room? Because I know I'm working, because I know I've been to a lot of the centers. Does it have to be a room, or can it just be a bed in a dedicated area of the ED?
It can be other ways.
Okay.
Yeah. When I say room, I mean really an area where you can provide those life-saving interventions quickly.
Okay.
Now, in many larger emergency departments, they have very large area with multiple beds, and they are multifunctional beds. And they say, well, any bed can be a resuscitation bed. In a smaller ED, you might want to start with a couple of resuscitation beds and expand that service across other beds. So that's one piece. So your level 1 triage patients, your sickest patient, can be sent from triage to the resuscitation.
Straight to that bed. Right. Yes. Okay.
And then you have another area separate from the resuscitation in many places called fast track or urgent care, where you can send your ankle sprains, where you can send your minor bruises, maybe small lacerations. So they are not competing with the resuscitation patient. So
we want to see them separately. We want to see the resuscitations in one side, and then we want to see the other walk-in ones on the other side. Okay, good.
And because sometimes you will have patients who will walk in, but they're very sick.
Yes.
So, you will triage them, do quick assessment. If they're very sick, they'll go to resuscitation even though they walked in.
Yes.
And sometimes ambulance people will come in, and they're not sick, you can send them to the fast track. But keep them separate. Because
separate the sick
decision-making, resources, everything is different. The mindset is very different.
So I think, that's also, we're getting to the questions now, which is actually some of the good questions. But I think just to summarize from what Junaid is saying is, you need to, so the immobile patients and those walking in need to come in through separate entrances. Ideally, you should have 2 separate triages. And the critically ill patients then are harnessed into the resuscitation area. And then the non-critically ill then directed. So trying to separate as much as possible. And I know we're not talking about having 2 separate buildings, though. It's just designating areas. And I'll tell you from my experiences, but just designating an area as resuscitation area and the others as maybe clinic area, that on its own then, as you said, changes the mindset of people, so that I know when I'm on this side, it's a thick, and you're on this side, then we'll be fine. So David Onderi, if someone has head injury, are you allowed to pump fluids to the patient? I think we've discussed around the fluids and not really trying to get to a normal blood pressure, but more maintaining systolics of 90, MAPs of about 65. Romeo, I think we discussed triage. Anyone can do triage. You just need to come together as a department, look at the available triage program. We recommend the WHO for now, because even the Ministry of Health normally will start with WHO. Look at that triage process, and it's available on the Emergency Medicine Kenya Foundation website. You can download it from there. Does NHI provide ambulance services for emergency? That's Moses. Actually, if you guys download, we've just updated, I know we've not told anyone, we've just updated the Casualty app. From the Casualty app, you can actually call NHIF directly. You can call NHIF Ambulance Access. So we've put in all these numbers, and what we're working on is for every county to put the emergency access number. So some of the counties actually have that number already. So it's already on the app. Get the app, and you'll be able to get some of these numbers. How often? Now we'll discuss training actually. I'll take that second question, and something I'll actually ask you, Nate, on this. We have someone from Pakistan, Punjab. I'm a medical officer in trauma. I have a question. How can we improve emergency department system and emergency care? Like, where do we start from if one is working in a teaching hospital? I think that's what we've been discussing all the way through. This podcast and recording will be available on Dr. A online, and we'll also put it on our website, and you'll be able to quickly actually answer some of that question. But in terms of training, I think we've discussed training from a pre-hospital perspective, training from the emergency department. Do we all need to go back to school, or is there an opportunity for in-service training? And what kind of in-service training should we be looking at, and how often should we be doing this?
Very important.
Yes.
I've been practicing for I don't know how long, and almost every month I do some sort of training.
Monthly.
Something comes up. My institution expects me to read this or read that, do this. Something is there.
So, yes, okay.
So that is the institutional requirement for keeping me up to date with things. Then there is, for the American board perspective, we have to sit for boards.
How often do you have to sit for boards?
So it used to be like every few years. Now it's every year. You have to do certain things every year. read some papers, sit for a minor test, make sure that they have, instead of waiting for 10 years, now they want you to be up to date every year.
Yeah.
So then, you're constantly reading and you're constantly getting up to date. I don't think in today's changing medicine, especially for emergency medicine, because we are affected by all the specialties.
Yes.
So we need to keep up to date, and going to the conferences is a great way to learn. But the answer to your question, big yes, you have to keep.
So yes, and I think first of all, I'm really appreciating everyone on this call, because this is what we talk about. So a lot of people think about gathering education or gathering knowledge as going to a course for 5 days or going to another different locality and learning for 2 weeks. But I think even just this platform we are on right now, Daktari Online, there is so much content that you can consume. So this will be at a podcast, meaning you can listen to this discussion as you have a cup of tea in the conference room. You can watch this video as you're relaxing in the house and use of social media. So I think we need to change the mentality that people have to go to a classroom to learn. There is so much information that's being pumped out. As a foundation, Emergency Medicine Kenya, we pump out a lot of information on our social media channels, on our website. As Daktari Online, they have so much content on their website that you can consume it when you want it, how you want it, and be able to say, so if you actually went through all the emergency content on Daktari Online, you'll be very good as an emergency care provider, because it's there, and it's there and it's really available for you. So I think that's one of the things that we really need to demystify, is that you don't need to go to school to learn emergency care. I think all of us inherently can learn aspects of patient care by actually using some of these resources. And I think teamwork, I think that's one of the things. So we've discussed how the AD should be designed, how the AD should be flow. One of the things I'm very passionate about, and a lot of our training has been focused on, is building teamwork. Because without teamwork, emergency care doesn't work. So I don't know what your perspective on this is.
Absolutely. So there's good evidence now that institutions that have trauma team, they tend to have better outcome.
What's a trauma team?
So good. I'm glad you're asking this question. So trauma is a multidisciplinary disease, and we need people for emergency medicine, surgeons, sometimes orthopedic surgeons or neurosurgeons, in places where airway is being managed by an anesthesiologist, and nurses, and a documenter who can write down what's going on. So there's a quality check later on. Those are the kind of people, when there's a sick enough trauma, a severe enough trauma, your institution need to have a mechanism. You can call that team, they all come together. Now, the problem is you can put that system together, people will come down. But when you talk about team, just imagine a football team. They all work together. Really, they have to pass the ball to each other, and they trust each other, and that's why the team works. In medicine, sometimes it's not as seen as normal. People feel that I'm a better physician or a better surgeon than you are. They can't work in the team. To work in the team, you have to respect each other. And so the institutions have responsibility of not only creating a team, but teaching teamwork together. How do you respect each other, and how do you work together? Once you have that structure, very important for us in trauma care, but for many other diseases, teamwork, working with nurses. If I have a patient with heart attack and needs to go to the cath lab, or if I need to talk to a cardiologist, for example, my nurse, my cardiologist will work together for the same aim. We're not competing with each other.
I think I like the analogy of the football team, because Kenyans love football. I think everyone is on APL and all other leagues that are there. And I like the concept that even in a football pitch, one passes the ball, if I pass this patient to this doctor or this nurse takes over the patient, then the care continues. Okay. So I think then is there a need for us to how do we build that? Because I know most people are looking at it like, the last time I spoke to the orthopedic surgeon, they were busy hurling profanities my way. Yeah. But how do we build teamwork in the AD, and how do we build teamwork across the hospital to be able to provide that care that's required for emergency patients?
Right. That is a leadership. That comes from leadership. If the leadership of the institution is committed to respect and focus on patient care before anything, then no, it doesn't matter how much revenue you're doing or how many surgeries you're doing. You have to work for the patient. That is the tone that leadership says. I think often actually, the juniors follow what they see as their seniors do. They emulate. So seniors have to fit that tone, and the institutional heads need to create an environment where everybody is respected and everybody's focused on patient care.
And I think that also starts in terms of those who are in the ED leadership. Right. I mean, being able to bring together your team, because to be honest, if your ED team is not functioning, I mean, if you're not working as a team within the ED, then trying to get everyone else to work with you as a team is probably a challenge. Because teamwork starts with your department before you start roping in other departments to say, oh, let's collaborate. So if there's chaos in your ED, then that. And a lot of this, as we're discussing, doesn't need you, because I'm seeing someone, where can I train in emergency course? Again, people, we need to look at, there's a lot of information that's available for you to train. And I see someone actually put in a nice question. Simulation. Should we be doing mock simulations of patients, and how useful is this in our setting?
Very helpful.
Okay.
I think when I was training, we didn't have as much simulation, so we made a lot of mistakes on patients. We can avoid many of those. Both in terms of decision making as well as skills. Simulation centers are, highly variable, but if you have access, but even if you don't have simulation centers, just using a healthy patient and just going through the process of decision making. So it's a simulated environment, a safe simulated environment where you're learning is very important. I think all of us have traditionally learned on patients.
Yes.
And now
we still learn on patients.
Right.
Yes.
We think learn on the patients, but also don't try and learn before you get to the patient. So you don't make the mistake in front of the patient.
In front of the patient. Okay, so good. So just to look at holistically the AD. So we discussed there has to be triage, the design has to be well. There's a need for continuous learning and continuous training of the staff within the AD. There's a need to build leadership within the AD, to build that teamwork within the AD and extending this to the rest of the hospital. Are there any other things we should be thinking about in terms of building effective emergency departments in our setting?
Yes. I feel nurses have a very important role in the emergency department, perhaps more than most other places. So they need to co-own the emergency department with the physician leadership, because without them, it doesn't work. Secondly, when people are scared to call their seniors, when they know that, oh, why did you call me? Or you should have known this. That culture promotes mistakes. So building a culture where it is okay to ask stupid questions. It is okay. You can call me. I will not judge you at that time. So that is, again, the leadership thing. I think having clear protocols and guidelines helps everybody. And sometimes, even after so many years of practice, I want to go and look at my guideline and see, I'm not sure. Let me look at the standard of care and make decisions based on that. So as you have done, Dr. Shira, in your setting, putting some time and giving as much guidance as possible.
Yeah. So having protocols. So we've given you free protocols. We actually you can get free protocols from the Emergency Medicine Kenya Foundation website, and we normally send this out to the facilities. I think there was a question I was saying there about research, which I think is your biggest passion. I know in our setting, we have these myths and misconceptions about research. It's too time consuming. It doesn't bring me any money for sure. I can promise that. And why? I mean, I'm not looking to be an academic. So what's the importance? I've seen this is a question from someone in Pakistan, but I think it applies in Pakistan, it applies in Kenya. What's the role of research? Like, should we be doing research in our setting, and why should we be doing research in emergency care specifically, or trauma care specifically in our setting? And what's the easiest way to do this and the cheapest way?
Yeah.
Yes.
When we say research, what we mean is to have a systematic way of answering a question. So that is all research is. It's not about writing a manuscript. It does help write a manuscript. But when you see a problem in your setup and you say, how do I fix this? That is a question.
That's a research question.
That's a research question.
Yes.
You see a patient, you said, something went wrong. I think I should have done this. That's a research question. And then you have several ways to answer that question. You can do a literature review to answer the research question.
So that means looking at who has asked similar questions again?
Right.
Yes.
So looking at literature, doing literature review, talking to your friends, saying, I have this question. And if that question has not been answered by anybody else, then you say, well, I think it's an important question. If I'm asking that question, perhaps others are also asking the question. Can I help? Can I do this research to answer that question? Or can I assist somebody to answer that question? So once you have question clear, then you think about what is the right method to answer that question. So you come to a methodology. Is it a clinical trial? Is it a pre and post? Can I just do a review of previous charts, a retrospective study, and answer that question? So then you come to the methodology, you define that, collect data based on your methodology, and do the analysis, and draw a conclusion. That is a process of research. Question that's bugging you, that's bothering you, that you think is going to make patient care better, thinking about how to answer that question, then collecting information, analyzing information, drawing conclusion. And if you have energy, then write it as a paper.
If you have energy, I like that part. I think one of the biggest gaps that exists in our system right now, and yes, I think we've all been asking the questions, is data. So many of our units do not collect data. And I think then that becomes a problem. Data in terms of being able to collect pre-hospital data at EMS facility, EMS unit level, at a hospital AD level, how important is data? Mainly looking at it from the perspective, I'm even going to move away from the research. How important is it to have data in terms of developing our emergency care systems?
I think it's very important. And the reason I say it is because today in the world of science, we make decisions based on information data, not what I think, what you think. Because, when we individually make decisions without data, sometimes we have to, we can make an error, but data doesn't lie. So we want to be truthful and we want to get data. Now, how do we get data? I've always struggled with that because I have, ran the emergency department being a clinician,
yes,
and then have been a researcher. And if I have been given a choice, I would always want my practitioners, my doctors and nurses to focus on the patient, not on research. Focus on the patient, provide the best care, and then collect the data you need for the patient care.
How?
Now, you have some standard formats now. WHO has one, several others, where you can have a standardized form, a trauma form, or emergency department form, where you can start collecting information, and all patients should. That data that you're collecting is actually very good for patient care, but also helpful for research. Some people, what they do, and maybe researchers will not like me, is let's ask the healthcare providers who are providing care to also collect data for me. I think it's wrong. I think if you really need to collect a lot of other data, then have somebody else assist.
A separate system.
Assist the data collection.
Okay.
Assist the data collection and not make your doctors and nurses do your research data collection. Just because
because then that's really, yes, the focus should be on the patient.
Right.
But I think in our documentation for the patient care, then that is then data that someone else can review and be able to collect. Because I think, to be honest, if your facility, your ambulance service or your emergency department is not collecting data, because you cannot know where you've come from or where to go to without the data. And today we had a meeting actually where those representatives from the Ministry of Health, and they were mentioning that they struggle because they're going to Treasury to justify a budget to get money from Treasury to fund something within emergency care. And the person at the meeting was like, unfortunately, it was struck off the budget because I don't have data. I know it's a good idea, but without data, then there's nothing. And I've had this same discussion with many policymakers where we cannot justify. We always say, and you say, we want ambulances, or ambulances are doing so much, or we want this, but where is the data? And I think this discussion actually has also opened up my mind to a lot of data numbers that we need one ambulance per 100,000 population. We need to get an ambulance to respond within 5 minutes if we're having an emergency, or 20 minutes. So these are factual data points that you then use in a discussion, you then use in an argument and trying to push for services. I think I look at some of the questions. So more often or not, there will be a driver or a rider with a license near an emergency scene. If emergency call centers were set up, working with the NTSA to have emergency contact numbers, include the driver's license, could be a viable options. I think that's also a good suggestion. I think there's a lot of, thank you very much. I think we really appreciate the questions and thank you very much. I see a lot of you are really enjoying the discussions. And I think it's not me, it's my great friend here, Prof. Junaid. So I think we're almost heading to the end of this. What would be your take-home points? Like, you have years of experience. You started from the beginning and you're still working in this system. And there's a lot of people in the audience or listening to this that are looking for some form of inspiration, because you started from the beginning, from where we are potentially, and here you are now, and things have developed over the years. What would be your take-home points? Like, what would you want us to leave kind of knowing?
Yeah, I think what will change the system is Ben Bashiras. People, leaders at all levels, when they say, I want to save lives and do not want my country or my city or my neighborhood to have this issue, you will find ways to do that. So let's create, and what you're trying to create is creating a community and bringing them together so you can support each other. So it's leadership, it's coming together, it's staying positive. Most important thing, because we have seen improvements in places where people said can never be done. Mm. And, we have, a lot of us have a habit of saying, it can't be done in my country.
In my community.
In my community, it can't be done. And then you surprise yourself and say, you know what, I went with a very clear agenda. I knew that I needed 30 ambulances with a response time of 10 minutes, and I needed this call center. I was very clear what I want. I could dream this, and I could paint a picture. I will get it.
Okay. Yes. I think, that's powerful. And I think, yes, and that's what we're really trying. And even with the community that's joined online and everyone else who works with us through the foundation and even working with the facilities, I think working together is something we really need to keep doing and keep dreaming and keep working and pushing to get some of these things implemented. So really, that's a very good take-home point. I'll just read some of the last comments and then probably we'll call it a day and invite Dr. online to talk. So let every health facility create an ED if none is that. I think that's a very good. Thank you very much, Modesta. Every facility you work in must have an emergency department. We have explained the components, and none of those components cost millions of shillings. It just needs the people, willpower, your leadership, your initiative actually to put in things like triage, develop different entrances. You don't even need to put up a whole building. Designate a resuscitation area. I think some of those things are things we can actually do from now. See, we've got Julius. We may talk about strengthening EDs is great, but it's talk about taking a long time to achieve meaningful progress regarding emergency care, functional EMS system. I think we've discussed that around EMS system. And I think of all the things that has come out from this discussion is how simple an EMS system should actually be. Because I think we always have this perspective, and again, from watching all these 911 shows on TV, that for us to have an EMS system, we need thousands of ambulances, thousands of trained providers. But if you actually look at it from their perspective, this scientific perspective, one ambulance per 100,000, 5 to 20-minute response with an average of 10, and go with these numbers to your policymakers. Because to be honest, if you go to a policymaker and tell them, we need 100 ambulances, they will laugh at you and move on. Okay? But if you now tell them, we have a population of 1 million people. If we get 10 ambulances and positioning them in this way so that we are having a 5 to 20-minute response, look at existing EMT providers, and probably since it's an urban area, then they will work on a bit of training, look at upscaling the existing nurses. So let's not think about out of the world things. And I think this discussion for me has been very helpful. Really, thank you, Nate. As I said, he's got a lot of experience, and we are riding on his experience to look at also how are we doing in things in our setting, and improving things. And let's move away from the perspective, as you said, it cannot be done, or we are at the mercy of a cartel. Let's not look at what cannot be done, but be more hopeful about what we can achieve. And I think I tell you for sure, a lot has been done in Kenya. And you think from Pakistan perspective, you have seen the difference that it has made over the years. And we look forward to getting to that level in Kenya and looking back and say, this is as far as we've gone. I think with that, I want to say thank you very much, Prof. Junaid. Really appreciate, and we'll continue working together.
It's an honor. Thanks.
Yes, you inspire a lot of us, and hopefully the inspiration translates to the ground people. So remember, we have this talks. So this is a webinar podcast. So it will be available as a video presentation. It will be available as a podcast through Daktari Online. And for us at Emergency Medicine Kenya Foundation, remember, download the Casualty app. It's fantastic. We've really listened to the feedback we've gotten and updated it. If you look at the new app, it has a lot of new things. For those who have Apple devices, we promise you by Christmas you'll have the Apple version of the app. That will be a Christmas present to all of you.